In Lesson 5, we have learned 4 areas and 4 steps of EBM. Currently, we are working on Step 3 for treatment, namely critical appraisal of a study on therapy. Critical appraisal itself has 3 steps: examining internal validity of the study, quantifying the obtained results, and examining its external validity. In this lesson, we focus on internal validity. So, what is internal validity? Internal validity examines if the study is true with regard to the subjects involved in that particular study. There are 5 checkpoints to examine internal validity. Look complicated? Well, if you have understood the ceteris paribus, it's easy. Checkpoints 1 and 4 examines susceptibility bias. Checkpoint 2 examines transfer bias. Part of checkpoint 3 examines detection bias. And part of checkpoint 3 and checkpoint 5 examines performance bias. It then follows that the first 3 checkpoints are the more important ones, and the last 2 points are less vital. Because if all checkpoints 1, 2, and 3 are ensured, then checkpoints 4 and 5 would usually follow. So let's see if our evidence candidate, the balanced trial, passes these internal validity checks. Checkpoint number 1. Were the patients randomized to treatments? Those of you who have already tried to critically appraise this article using the critical appraisal worksheet that you downloaded from our homepage, please look at your own answers. Our answer is yes. Because randomization is so crucial to assuring ceteris paribus and is such a big virtue for a study, it is usually indicated in the title of the study itself. Was the randomization concealed? Yes. In the text it says, treatment allocation was via the 24-hour telephone service at the Clinical Trial Service Unit, University of Oxford. Investigators telephoned the service and logged the patient as eligible for randomization. The investigator was then informed of the treatment allocation. Please note that allocation concealment is different from blinding. Allocation concealment takes place before randomization and blinding after randomization. The allocation to treatment is concealed if the personnel entering the patient into the trial does not know which arm the next patient will be allocated to when he or she enrolls the patient. Checkpoint number 2. Were all the randomized patients accounted for at the end of the trial? Yes. Nowadays, most, if not all, reports of randomized controlled trials have a flowchart like this. This is the so-called consort flowchart, because it is one of the many recommended items according to the consort guideline for reporting RCTs. The consort flowchart is really informative and shows the fate of all the randomized participants. With information from the consort flowchart, you can assess how closely the authors have followed the intention to treat principle in their analysis. In the ITT analysis, you take the number randomized as the denominator. The opposite of the ITT analysis is the so-called per protocol or completer analysis, in which the denominator is the number of participants who have completed the study according to the protocol. Regrettably, what is described as ITT analysis in the literature is often not strictly following this ITT principle, because their so-called ITT analyses often omit some participants who had been randomized but, for example, never returned. You can check if such a decision on the part of the authors can have biased the analysis by examining the consort flowchart. Number 3. Were the patients, therapists, assessors, and data analysts blind to allocated treatments? No. It is written, investigators and participants were aware of treatment allocation. However, the authors add, the consequent risk of performance and ascertainment biases was managed by restriction of randomization to patients for whom there was no strong treatment preference on the part of the patient or clinician, and by careful verification of outcomes. All outcome events were considered by the trial management team, who were masked to treatment assignment. Shall we read on? I guess we can.